knew I'd forget something. That's the click, and that's one to go forward.
Good morning, everybody. I'm actually Claire Fry. I've actually changed my surname since the programme was done, but it's still me. So I'm the matron for Intrapartum Services at UHCW in Coventry, and although on the bill we're actually talking about the first 1,000 days, because we've only got quite a short time, we're actually going to concentrate on the postnatal period at UHCW. I was invited to talk here following an article that I wrote for the Practicing Midwife in 2013-14. At that time, I was a newly appointed matron at the Trust, and obviously I wanted to make a change and make my mark in that role. And one of the things that I noticed when I'd been a Band 6 and Band 7 midwife was about the poor experience that our women experience on the postnatal ward. We had a very, very high complaint rate on the postnatal ward. So as a newly appointed matron, the first thing that I did with a maternity support worker was the 15-step challenge, walked onto the ward and helped, and together we identified a lot of the issues that were affecting the women's journey through our maternity unit. And with that, I launched the ImPosE project, which stood for Improving Postnatal Experience. That was launched in 2013, and we made a lot of changes, which we're going to talk about together. And I invited Claire to come today because we have a very forward-thinking head of midwifery. Our workforce is rotational, including us. So we've actually swapped roles in January this year. So Claire now manages the inpatient service, and I now manage the Intrapartum service, which is why I invited Claire to come with me today.
Right, so a bit about where we actually work. University Hospitals Coventry in Warwickshire is in the West Midlands, as you probably all are aware. We are a very large teaching hospital with over 6,000 deliveries per year. Our obstetric and midwifery services consist of a high-risk labour ward with a triage area. Historically, that was just one area that we used to allocate the staff to what we called admissions at that point, but there was a piece of work that was done prior to this, and we separated the two so that we actually run a separate triage area, and there are 6 beds in the triage area. We use one of them as a triage room, which is much like an A&E situation, and women are RAG rated according to the condition that they've come in with. On the labour ward, we have 15 beds. There are 2 high-risk induction beds, a pool room with a static birthing pool, a multi-birth room, which essentially is 1 bed, obviously for the mother, but we have 2 resuscitaires, and it's a larger room to accommodate the extra staff that are required. We have 9 birthing rooms that are just the standard birthing rooms, and 2 high dependencies, and then at the end of the labour ward is our obstetric theatre, which we recently have what's the word? Outsourced, that's the word, to general theatres, so we don't manage that anymore, we just supply the midwife. As I say, we're a large teaching hospital. We have seen our birth rate increased steadily over the last few years, and also not only an increase in the birth rate, but actually an increase in the complexities of our ladies. And in addition, we are also a dispersal site for refugees and asylum seekers. So along with everything else comes the additional problems that these ladies have. Our midwifery staffing and support staffing comes to over 200 heads. Our midwives are from Band 5 to Band 7. Band 7s are ward managers and coordinators, and then we have 3 modern matrons and a maternity risk manager who are at an 8A. And with that, we have our support staff, maternity healthcare support workers, and previously we had an initiative to train our support workers in theatre when we owned our theatre, and we trained 4 of our support workers up to a Band 4 level, and they are now theatre practitioners. In addition to that, some of our healthcare support workers, which I'll describe later, have also taken on additional roles, and we do have some Band 3s. In 2011-12, our head of midwifery commissioned a review of the maternity service, and on the back of that there was a huge investment from the trust to increase our staffing both for midwives and healthcare support workers. And so we revised all of our staffing establishments. At that time, the whole of maternity was managed under one budget, but we had to basically split it into areas. So we now have separate budgets for all the different areas. Again, our head of midwifery was doing some work with the Centre for Workforce Intelligence, which is where a lot of the initiatives around the band 3s and 4s came from. But we had many unhappy staff because there was no rhyme or reason really to where people worked, and although everybody is contracted as a rotational midwife, we all know that we all have our favourite place to work, but it seemed that people just didn't want to go to the postnatal ward. It was an area where it was just groundhog day because of the busyness of the unit. You know, you'd go in one morning, you'd do everything for everybody in one day, they'd all go home, and you'd go back the next morning and there you were again, same place but different faces. There was no real ownership, and it just didn't feel like a very good place to work.
So if we go back to 2013, on the postnatal ward, it's a 34-bedded ward, 6 4-bedded bays, 6 side rooms and 4 family rooms. In 2013 we had a 28% caesarean section rate, and the average length of stay was long in the hospital. It was 3.88 days, and that was for a normal birth with complication. We saw the safeguarding activity increase at the trust by 78%. We have a lot of high-risk ladies on child protection plans, and obviously because we're a city hospital, there's a lot of issues around the women that we care for. There was no format to the newborn initial physical examinations, and we had an increase in clinical adverse events, so things like ladies not getting pain relief on time, missed antibiotics for babies. We had a massive increase in babies falling out of beds or women dropping their babies when they were in bed with their baby, an increase in security issues, and our breastfeeding initiation rate was 77.59, which was below the target that was set for us by the CCG. So our Cinderella Story started in 2013, and the main issue around why I launched this project was around poor experience that women were experiencing, because that's what's important to me. I want all the women that come through the maternity service to have a good experience right the way from antenatal clinic all the way to when they go home, and they shouldn't have a different experience as they move through the departments, and that's something that we both feel quite passionately about. So we spoke to the women, the matron spoke to the women, we went out on social media and we asked the women to be very honest with us about their experiences through Facebook and through Twitter. Back then we had an increase in complaints, we had poor feedback on our friends and family tests, and we had poor job satisfaction for the midwifery staff that were working on the postnatal ward. We also had a large increase in resignation and leavers. And when we did our exit interviews for the midwives, it was because they were burnt out and they didn't enjoy working on the postnatal ward. There was poor team working across the unit, and this poor team working mixed with things not being quite managed properly led to bed blocking and delays. There was a lot of occasions where managers were contacted out of hours because the postnatal ward was full and the main labour ward was full of ladies that had their babies, preventing ladies then that were on the antenatal ward coming down to labour ward. So something had to change. We were heavily reliant on the postnatal ward on bank staff. We've never used agency at our trust, but although we have amazing bank staff, they come for 1 shift a week, so we never really had anybody that took ownership of the postnatal ward when they were there. So we began our transformation on the ward by using a quality management approach and putting customer experience at the core of the change. So we followed quality management principles, and we were able to use what we had learned from customer experience and develop a process and system approach to the ward activities. Now, it's important to say that although we developed a process and system, all of these processes were around what the women were telling us that they wanted. So it wasn't we made the decision that we were going to do this, it was what the women told us that they were experiencing. So we based everything around what they were telling us. And the main agenda, which Claire will go into in more details, was around staffing. So we reviewed the establishment on the postnatal ward and increased the staffing on the postnatal ward of midwives and of support workers, introduced an open curtain policy, a designated discharge midwife, reintroduced nursery nurses and changed how we gave the postnatal information to the ladies and their partners, changed the visiting hours, had investment in our infant feeding team and also investment into the newborn initial physical examination clinic.
Okay, so it became apparent that this whole flow of the patient's journey throughout the unit probably was getting stuck. The bottleneck was in the postnatal ward. So we needed to try and facilitate an easier journey for our women and at the same time improve the experience that they were getting. So I suppose as midwives, many of our the things that we just do automatically, but we didn't really have anything written down that said, yeah, that's fine for you to do that. So we introduced, if possible, all women, once they'd had their babies, if they were birthed on the labour ward, on the high-risk area, that if everything was okay and everything was normal following the birth, that they were in the realms of normality, that the doctor would discharge them there and then from the labour ward to the postnatal ward and return them back to midwifery-led care. That wasn't a particularly new thing, but we needed something that gave the midwives some ability to just continue. All TTOs, if they were required, were also written up at that time on the labour ward, so that the discharge the following day wouldn't be delayed because we were waiting for any TTOs or anything else. We had the designated discharge midwife, so it's usually the person in charge of the ward. They can be identified by what they wear yellow epaulets, and essentially their initial task of the day was at handover in the morning. They would realise which ladies would be suitable to go home that day. They would then liaise with the NIPE practitioner who would be working in the clinic, which I'll come to. The workload would be prioritised, and we also started using our ward clerks to assist with the actual inputting of the discharge information into our maternity system, which is historically only midwives had ever done. We called it the Home for Lunch campaign. So basically what we did try to do was identify those ladies perhaps that had had their babies at 11, 12 o'clock the night before, so they would be ready as soon as to have their baby examination performed, and then the rest of the discharge process. And then at 10 o'clock every morning there is a daily postnatal information session which the discharge midwife leads. So all the ladies who have been identified as going home would meet in the breastfeeding lounge. So you all know you're allocated however many you are. In our circumstance it could be 8, it could be 12 ladies and babies that you would be responsible for. So what you do is you go around, you do your postnatal examination, you do your baby examination, you tell them all the information, and then you go to the next lady, and so it goes on. It's very repetitive, and obviously there's to save time, having the ladies all in one place, it sort of promotes a conversation, it promotes debate, it promotes questions that perhaps another lady might not have thought of, and if we can, we also try and do a bath demonstration, or perhaps feeding, making up of feeds demonstrations if there's time, which is something that probably over the years through the busyness had got lost. In addition to that, at the same time, we had, with the investment from the government, we had been granted £750,000. That was to open our birth centre. So that also helped, because obviously we had so many hundred women that would have previously gone through the labour ward and come to the postnatal ward were now being birthed in our birth centre. So that did help as well with the flow of patients or ladies. And then in September 2014, the Enhanced Recovery Project was launched, whereby our elective caesarean sections under spinal were given diamorphine for their spinal anaesthetic. Now this has also had a massive impact on the length of stay for our ladies. So in May 2014, if you had an elective caesarean section with complications, your length of stay would probably have been around 3.6 days, and without complications around 2.9. In May 15, the data shows that without complications, your length of stay would now be 1.4 days, with complications only 2 days. So you can see that that as well has made a big difference. And then there's the comments there that we've taken from our impressions to show that generally the women are much more happier with the experience that they're having on our ward. So in line with all of this, with the discharge midwife and the process, we converted one of our nurseries into a NIPE clinic. We have invested in 30 midwives being trained in the examinations, and they work alongside an allocated paediatrician or neonatologist. We as midwives obviously only see those babies that are normal, with the ability to refer to the neonatologist if necessary. BCGs are all given as they're required to save time. Previously we used to do it all at 2 o'clock in the afternoon, which again would cause delays. The NIPE clinic is open 7 days a week on the ward, and we also have very close links with Coventry University, and our student midwives now undergo the theoretical part of the NIPE module. So once they're qualified, they are ready then to do the practice when they come out into the wards. As Claire mentioned before, we reintroduced nursery nurses, and we also revised the role of our healthcare support workers, and we've had 10 of those have gone through a level 3 diploma, and they do additional tasks now, such as the care of the high-risk babies alongside the nursery nurses, and blood sugars, and one of them is our hand hygiene trainer. They do observations, etc. Okay, experience and environment, as Claire said, it was a You Said We Did campaign. We surveyed our women, and the open curtain policy was devised in that you would walk onto the ward, and in our 4-bedders, all you would see was a sea of curtain. You just couldn't see anybody. So we make a point of opening the curtains and explaining to the ladies that not only, you know, does it give them the ability to talk to the person next to them, but actually we're able to see them. Claire referred to a couple of baby drops. That's with the curtains round, ladies feeding her baby, drops off, and the baby rolls out onto the floor. And so, again, this was a way for us to be able to see our ladies at all times. The ladies told us that they wanted their partners and children to be able to visit most of the day, so we changed our visiting from 9:30 to 9:30. We also invested in a few put-me-up beds for our side rooms so that partners are encouraged to stay. That in itself was a massive call to change, particularly for those that work at night, because some of them don't like it and still don't like it. And didn't you know this is an institution? We can't have people here all of the time. That was one of the comments that one of the midwives made to me. Claire and I really both do have a massive focus on the women's and families' experience and their environment around them. So, you know, we're continually looking at ways to improve, but also continually listening to the women and their families alike.
Okay, so we're almost at our happily ever after. The complaints have halved about the postnatal ward. In fact, our complaints have halved in general, and it's been a really positive change for the maternity unit, for the women that are using our service, but also for the staff that work in the service as well. Any complaints that we've had over the last couple of years have now been shared with staff, and we ask the staff that are involved in those complaints to actually respond to them. We anonymise them, we put them in the staff room so that the staff can see what women are experiencing when they come and use our service. We display the comments from our friends and family test cards and from our trust's own impression surveys, and that's been a real boost for the staff because they can see on a weekly basis what the women are saying about the care that they've had across the maternity unit. The ward meetings have been much better attended, and the project has really brought the unit back together and not made it feel like it was everybody working in separate units. The teamwork across the whole unit has improved greatly, and the feedback from the women, I mean, most importantly from the surveys that we had, but also from some of the community midwives, some of them are in the audience actually, the women's experience when they go back out to their own homes has been amazing compared to what it was a few years ago, which has been a really, really positive thing for us.
So where do we go from here? We're continually looking to improve our service, and these are just some of the things that we hope to achieve. A lot of our recruitment and retention is amazing. We don't have any vacancies now whatsoever, and that's probably down to the use of social media actually, going out of our way to say this is what we do at UHCW. We are going further with the Mum+1 project in that we are going to extend that into 4-bedded rooms. Obviously, we've got to bear in mind the cultures of our other ladies, and we won't obviously allow anybody to just come and strip off to their boxer shorts and get into a bed next to their partner. But that's something that we do want to extend. We're working towards level 2 baby friendly with UNICEF, and we hope at some point to have a specialist perinatal mental health midwife in post as well. I already mentioned the band 3 HCAs, which again with some further investment we can extend that into the workforce. So thank you.
Thank you.